Firstly, I would like to thank the IMA Nasik and the ISHBT, particularly Maitri ma'am, Shinaz ma'am, Pati sir, and Dr. Siddhant, my good friend, for giving me this opportunity to talk and speak in front of you. Now, this would be the overview of my talk, and these are the SLOs for the day. Now, when the topic was given to me, I asked, okay, why do I need to take a lecture on this? So then Siddhant told me, okay, irrespective of the specialty, this is a very important topic. Repeated hematology calls from all peripheral hospitals that he keeps getting, and they keep disturbing him overnight for thrombocytopenia. And third, he said, cost of patient goes up tremendously whenever there is thrombocytopenia in ICU. The first two I could understand, but the third one I didn't understand. So I asked him, how? Then he gave me this explanation. Thrombocytopenia hote hi papite ke juice, this is a cost. Papite ke fruits, this is a cost. Kiwi, this cost. And bakri ka milk, this cost. I said, ये भी समझ में आ गया, but ये बीच में kiwi का fruit अचानक 2400 क्यों हो गया? Then he says, it also includes that beautiful lady and giving consultation thrice in a day. So that also is included. So today we are going to talk about anything but for this as far as thrombocytopenia in ICU settings is concerned. No intended harm to animals, persons, or any opinions or beliefs. Again, when he distributed topics, he distributed RBCs to somebody, WBCs to somebody, platelets to somebody. I said, this poor guy platelet sitting in between, chota sa, ki, am I important? Yes, it is important. So when I showed the same photograph to my undergraduates, I said, what do you interpret from this photograph? So the bright sparking minds, they say, sir, Ramdev Baba, you have to give all these fruits along with it to improve platelets. I said, no, something else. They said, it's like batata, kanda or tamata in Maharashtra, wherein you can put platelets into any part of the disorders and it becomes a part of it. And they are actually right. Platelets, other than bleeding, they are also important for various other functions, which we are going to see for the day. And that's why we are talking about thrombocytopenia in ICU settings. Now, let's look at things other than the primary hemostasis. As we all understand, as the chairperson just said, dengue, low platelet count, having problems, you need to count on them and act upon it. Yeah, though everybody knows. Now, it also has a role in endothelial dysfunction. Like you have a new house, there are cracks in it, the platelets goes and plugs it. It need not be for stopping bleeding, but for maintaining endothelial function. You require this platelet, and these are the micro photographs to prove the same. Inflammation, it has a huge role to play. What it basically does is, in an inflamed endothelium, there are multiple ways that the platelet comes and attaches to the endothelium and tries to either activate endothelial dysfunction or suppress the endothelial dysfunction, which we'll talk about in a moment. Platelets are antimicrobial in nature. In fact, there have been randomized control trials wherein people have seen that patient not improving on the best of the antibiotics, platelets, though patient might improve. Yes, there is a concept behind that because platelets are working in different ways in activating your immune system and also direct action against gram-positive and gram-negative bacteria. But do we need to transfuse every patient who is having polymicrobial resistance platelets? Actually not so. We'll look about it in a minute later. Other than the primary hemostasis, it also has a role in a secondary hemostasis. How? The intrinsic pathway, extrinsic pathway is the old Jamana concept. Nowadays, we talk about a cell-based technique of coagulation. And platelets are a centerpiece as far as the coagulation cascade has to start or to propagate or to stop. So, for all the three buttons, fast forward, stop, play, platelets are important. Tumor biology, extremely important. Platelets have a role in metastasis of most of the solid malignancies. They have a role in propagation of the tumor, survival of the tumor cells, and whenever you are giving chemotherapy and you say resistance ho gaya, there are many concepts for resistance, but one of the concept also happens to be the platelets, which is shielding these cells and preventing the engulfing of the cancer cell by the therapy that you are giving. Therefore, many of the solid malignancies, if any oncologist here or anybody who is following up solid malignancy patients would understand, people give aspirin in colon malignancy, people give aspirin for prophylaxis of some of the solid malignancies. The concept comes from here. Now, so with this, this becomes this. Yes, I'm important, and that's why we are talking about this topic today. Now, as far as in the ICU setting is concerned, all these concepts I have shown you are active at the same time. So, platelets is also activating macrophages, leading to phagocytosis. Platelets is getting activated, leading to coagulation. Platelet is leading to some amount of antimicrobial activity. It is leading to leukocyte recruitment and activation. It is leading to antigen presentation. It is leading to activation of neutrophils. So, they are extremely active, and therefore, the increase or decrease in number of platelets at this particular point of time can have prognostic as well as therapeutic significance. Now, these are the consequences. So, the beneficial effects are wound healing, vascular remodeling, enhanced integrity of endothelial membranes, reduction in vascular permeability, and mediation of inflammatory process. Harmful effects, it leads to impairment of microcirculatory flow. As this is a mixed audience, we all understand. The most important concept in ICU is good perfusion to the peripheral tissue. Concept is simple. If you have this, the patient survives, gets out of your ICU in a walking status. If you are not able to take care of it, he goes out of the ICU still, but on a mortuary table. So, for maintaining this perfusion, platelets are a very important factor, and if there is a platelet activation, there is an impairment of the microcirculatory flow. Propagation of inflammatory and coagulation cascades is a harmful effect of it. Now, so as far as the part 1 is concerned, platelets are versatile. They are more than a bleeding blood plugs to prevent bleeding. They have an active role in inflammation. Platelet dysfunction can lead to multiple comorbidities. Multiple comorbidities can lead to platelet dysfunction. So it's a dual way traffic wherein it can act both ways. Now, coming to epidemiology of thrombocytopenia in ICU settings. If you define platelets as less than 1.5 lakhs as thrombocytopenia, then the prevalence in ICU is 8 to 68%. The incidence is around 14 to 44%. That means patient came normal to you with normal platelet counts, but he developed thrombocytopenia while in the ICU in around 14 to 44%. That means almost half of your patients have a propensity to develop thrombocytopenia. This variability in this 8 to 68, 8 kaha, 68 kaha, this is because it all depends upon what is your patient clientele. Are you managing cardiac ICU? Are you managing liver ICU? Are you managing general ICU, surgical ICU? It all depends upon that. It also depends upon the definition of thrombocytopenia that you are taking. If you take thrombocytopenia as less than 50,000, you will have a lower problem. If you take it less than 1.5, like you will have a larger population. Also, on a lighter note, it all depends upon if for increasing your bills and your hospital income, if you admit every dengue patient to the ICU, obviously the thrombocytopenia in ICU becomes 100% incidence. So, other than that, if you go scientifically, these are the facts. Now, I will show you some data to suggest the same. So, PROTECT trial is the largest trial which has been done as far as the thrombocytopenia in ICU is concerned. So, they said the prevalence is around 26% and incidence, if you take 1 to 1.5 lakh, 15%, moderate 5%, and severe only 1.6%. I want you to concentrate on the last part, less than 50,000. So, not many people will develop severe thrombocytopenia while in ICU. But even a mild fall and a moderate fall has a relevance, which I will be discussing in the further slides. Now, this is depending upon the type of clientele. So, if you see various graphs and the platelet counts with the days in ICU, you will find in cardiac surgery, trauma, abdominal surgery, medical, you will have different types of patients and different types of incidents and different type of the trajectory of the platelets. So, there are some practical tips. Thrombocytopenia that develops after your arrival to the ICU is because of you. Very simple. You means one, it's either because of the intervention, either surgery, fluid resuscitation, drugs, or the patient has developed a complication, either in the form of sepsis or liver impairment. If the patient has thrombocytopenia before coming to you, it is because of a preceding illness. But if it has occurred after he has come to you, these are the important things. Second, the timing or course of thrombocytopenia suggests the diagnosis, which we will discuss further. So the second take-home message is the incidence or prevalence depends upon how do you define and what is the type of clientele that you are taking care of. Now the third part that we are going to discuss about is causes. So common, less common, uncommon. So common causes, these are the common causes which can lead to thrombocytopenia in the ICU settings. Less common causes, HIT, HLH, big terms, we'll not go into the details. Uncommon are drug-induced, leukemias, MDS, aplastic anemia. So I'll definitely not touch about this or talk about this. So coming to pathophysiology. Now this is a very, very important component of the complete lecture, because my professor of medicine in MBBS used to tell pathology बहुत important है for every clinician. You should marry a pathology. I never understood that till the time I entered hematology, where I realized 90% of hematologists are married to pathologists. So ध्यान से, if you say anything ill about pathology, so mechanisms of thrombocytopenia, the pathophysiology, firstly is very poorly understood, as poorly as you understand your wife. Multiple potential causes, and tool to distinguish among them is very limited. We just don't understand how to distinguish one from other. But still, I'll make an effort to differentiate each one of them and tell you the clinical relevance of it. First thing, already discussed in the previous lecture and also by the chair, about pseudothrombocytopenia. So, as they have told, it's much more commoner in ICU setting. Why? Because the antibodies to EDTA or the chelation are more commoner in ICU settings because of the endothelial dysfunction, because of the various problems which are occurring. So, please remember pseudothrombocytopenia as the first cause as far as thrombocytopenia in ICU is concerned. Other than EDTA chelation, the other factors are dilution, sampling, lag between collection. I'll spend 1 second on dilution and sampling. Now, why that is important is, patient का central line लटक रहा है यहाँ से, the hematologist has said, हर दिन platelets चाहिए मुझे. What happens? The nurse who is there or the paramedic who is there, तब तक IV fluid normal saline चल रहा था, वहीं से draw किया, sample भेज दिया. आधा तो normal saline था, उसके अंदर खून कम, normal saline ज़्यादा था. So obviously your platelet count will be lower. Second, dilution because of excess IV fluids, because sepsis bundles, आजकल तो सब मतलब everything goes based on मतलब algorithm bundles. The critical care physician says ये bundle में इतना लिखा हुआ है कि इतना fluid देना ही देना है patient को, कुछ भी हो जाए, whatever hematologist says. Hemodilution occurs, and that's a very, very common cause at this stage. So please remember, dilution and sampling are very important aspects. Sample from periphery whenever you have a query of thrombocytopenia. Now, coming to pathophysiology, this is a pyramid of various causes. So we'll go one by one. The second commonest cause after pseudothrombocytopenia happens to be consumption via thrombin-mediated platelet activation. Angrezi bahut, but the concept is, in your critical care patients, there is an activation of coagulation cascade that leads to consumption of platelets, leading to fall in platelets. In simple terms, DIC, disseminated intravascular coagulation. Two types, overt and subclinical. Overt, very easy. You check the PT, APTT, D-dimer and fibrinogen. Ab dekh lo, if the patient has an abnormal PT, abnormal APTT, abnormal fibrinogen, abnormal D-dimers, high D-dimers, low fibrinogen, clear-cut DIC, no problem. So these patients have high bleeding tendency. But why did I put this bulb here? The point is, whenever a patient has a DIC, the cutoff for platelet transfusion goes up. You need to transfuse the patient even if the patient has a platelet count of 50,000. Whereas, in a patient who does not have an associated bleeding tendency, you need not give platelets till the time the patient has a platelet of 10 to 20,000. So, associated bleeding tendency is an indication for platelet transfusion in critically ill patients even without consulting hematologist at a higher threshold, because patient has a propensity to bleed. Second aspect, fibrinogen is an acute phase reactant. So, fibrinogen might not be low. When we looked at PT-APTT in various studies, up to 50% of the normal patient with a clear DIC has a normal PT-APTT. So PT-APTT normal hai, fibrinogen bhi normal hai, ya in fact zyada hai. So, but you strongly suspect that this is DIC. What do you need to do? Do D-dimers. Whenever you have a low platelets in a patient with sepsis, uska साथ साथ D-dimer कराते रहिए. If D-dimer is elevated or is gradually increasing, the patient has got a subclinical DIC. And you can use this criteria for again understanding that this patient has got a bleeding tendency. Now, thrombocytopenia with abnormal PT-APTTs. What are the two main causes? एक तो DIC हमने देख ही लिया. The second one is liver dysfunction. It's very important to understand. Liver enzymes are not a synchronon for liver dysfunction. You can have normal AST, ALT, but liver 30, 40%, 50% damaged. There is a concept of shock liver. For all those who are working in ICUs or who are in critical care would understand this term, which means because of the insult of hypoxia, hypoperfusion, the liver can get damaged. You will have only abnormal LFTs when 90% of the liver is damaged. But for causing problems in the patient, 20-30% damage is sufficient enough. How will you identify? By abnormal PT and APTT. So, it's very important to differentiate DIC versus liver dysfunction. When you have a doubt, please call a hematologist. I will not give you an answer for this because nahi to hamari tankha kam ho jayegi. Okay, next, thrombocytopenia with thrombosis. Whenever a patient has low platelet count, you presume them to bleed. But yahan to thrombose kar raha hai. Why is he thrombosing? Because of the following conditions. So DIC, shock liver, catastrophic Apla syndrome, HIT, malignancy or TTP. These are the differentials that you need to consider. Now, you have got a patient of thrombocytopenia. But patient has also got anemia, patient has also got leukopenia. What will you consider? You will consider these four possibilities. Either immune-mediated destruction, splenic sequestration, hemophagocytosis or hypoproliferation. Now, जब ये सब कम हो रहे हैं, you need not bother, you can call us, but for a general understanding at a general physician level, evaluation before you call a hematologist, please first get an ultrasound, simple test of liver and spleen. Why? The first one, that is splenic sequestration, can be easily picked up by a large spleen or with an abnormal or increased echogenicity of liver. Second, do a DCT ICT. If a patient has got abnormal DCT ICT, there is an immune mediation. अगर ये दोनों नहीं है, then get a bone marrow or order for a bone marrow or request for a bone marrow. If a patient has got an immune mediated or HLH, IVIG is an important treatment, plus minus steroids. But if there is hypoproliferation or bone marrow suppression, how does it make a difference for a general physician? Again, the cutoff for platelet transfusions is much higher when you have a hypoproliferative marrow. ये जितने भी कट ऑफ्स हम बात करते हैं ना 20,000, 30,000, 10,000 करना है, these are all based on the studies from hypoproliferative marrow. So considering that, you need to make sure that the cutoffs are adequate. If there is no hypoproliferation on the marrow, you can just wait and watch and need not give platelet transfusion. The body will take care of itself for whatever is required, so you don't need to bother about it. Now, any nephrologists here in the audience? Oh, wonderful. And any cardiologists or any people? Okay. So, artificial membranes, a major problem. Most of your ICU patients, आजकल with the availability of nephrology help and with the availability of dialysis machine, हम लोग CRRT पे डाल देते हैं. CRRT, 75% of them will develop a fall in platelets. Cardiac assist device, 85% will develop. And those who are on ECMO, 100% will develop. Now, this was during the COVID pandemic. You find that thrombocytopenia is a major problem because of one of these three reasons. And the causes are all these things. But a small tip, how can you prevent it? So in CRRT, by just increasing the speed with consultation with nephrologist for sure, you can definitely decrease the fall of platelets. So the flow rate, higher flow rate, low fall. Lower flow rate, high fall, because the membrane retains the platelets. अगर तुम जल्दी स्पीड से दौड़ा दोगे प्लेटलेट उसके सामने से, it can't be retained. Therefore, by increasing flow rate, you can decrease the fall in platelets. Second, type of filters that are used. Polysulfone, commonly used, very cheap, but lead to a lot of thrombocytopenia. Cellulose triacetate, costly, but low thrombocytopenia. So depending upon the filters, you can decrease it. Okay? Now, if the patient develops within 1 to 4 days, then it is probably either because of hemodilution or because of the post-surgery or trauma, wherein all the platelets have got adhered to the vascular endothelium and are used in wound healing. So in those situations, you don't need to do anything. अगर platelets ICU के आने के पहले 4 दिन के अंदर गिर रहे हैं, just don't do anything. Histones is a new concept. I am just putting it here just to understand that it's also there. Now, antibodies. Previously asked, drugs. So there are various drugs, and as asked by one of the audience, this is a link which I have given here. Based on the link, all of you can use it in your mobile apps. You will come to know out of the drugs that you are prescribing, which all can lead to thrombocytopenia, and can preferably avoid that, because in an ICU setting, there is polypharmacy going on. And nowadays, in an era of subspecialty, हर subspecialty चाहता है उसके 3 दवाइयाँ जरूर होनी चाहिए. Okay, so at the end of it, patient has 20 drugs going on. So please look at the type of drugs and their interactions, and you can take off all those which can lead to it. So thrombocytopenia is multifactorial. Now, as a prognostic marker, if a patient is having persevering fall in platelet count despite of whatever you are doing in a patient with sepsis or who is critically ill, that means it's time for him घंटी बजाने के लिए. Okay? Because platelets are one of the worst prognostic markers. You do Apache scores, you do SOFA scores. There have been number of trials which have proven just by monitoring serial platelet counts, you can prognosticate patients for criticality. Okay, so platelets can be a surrogate cheap marker in countries like India, wherein you can understand that the patient is not improving despite of whatever you are doing. So these are various graphs to show the same, that जिन लोगों का platelet कम होता है and persistently कम होता है, they will not do well. So important prognostic marker, cheap and easy to use. Now last part, how do I approach after all these things? ये सब सुनने के बाद, thoroughly confused हो जाने के बाद, what should I do when I go back? So the topic today for me, अब मेरा topic talk शुरू होगा for 20 minutes. Past, present and future. So the ICU in critical care settings of past. So past means please take a context. Why did the patient get to admitted to the ICU? So a good history taking. Second, is there evidence of pre-existing illness or a known drug which was leading to thrombocytopenia? Could the ICU admission have been precipitated by any catastrophic illness like CAPS, TTP, HLH, etc.? And was there a history of major trauma or surgery in the recent past? Now, these are the various things to make you understand that depending upon these history itself, you can identify what is the most probable cause. Now, present तीन चीजें हैं, trajectory, severity and thrombosis है या नहीं है. So platelet trajectory, what am I meaning by that? Now most of you as general physicians would understand, हम सब लोग temperature chart maintain करते हैं ICU के अंदर, pulse का chart maintain करते हैं, respiratory rate का chart maintain करते हैं. But how many of us maintain a platelet chart? It's very important, just because the topic was given to me. So platelet chart maintain करने पे you can understand how and why is the platelet low in this given patient. So if a patient presents with low platelets and his platelets are remaining low, you think of pre-existing condition and marrow failure. If patient's platelets have fallen immediately after coming to the ICU and have recovered very fast, think of major surgeries or massive transfusions as we were discussing yesterday. If it falls in the first few days, stays low for a few days and then starts rising, then think of sepsis, pancreatitis, burns or multi-organ dysfunction. Most important, पहले तीनों चीजें तो समझ में आ जाएंगी, but the last part, multi-organ dysfunction, this might be an early marker for MODS in your patient. It falls and it stays low. Consider iatrogenic causes, drugs very importantly. Falls in first few days and stays low in a patient with persistent multi-organ failure. This means that your patient is not doing well and is not going to do well. So that was as far as trajectory is concerned. Coming to severity, with the permission of chair, 1 more minute ma'am, I'll just finish it in another 2 minutes. So severity. Now most of the causes, as I told you, platelets less than 20,000 is not a possibility in your ICU settings. If it is really less than 20,000, please call a hematologist. Don't try to make it that Colonel Uday had taken a lecture, therefore मैं आज से खुद इलाज करना शुरू कर लूँगा. No. Because all these causes you require a hematology help for managing, please call hematologist and please call Dr. Kalantri and increase his reimbursements so that for the reason that he has taken care of our hospitality very well. So thrombosis. Presence of thrombosis, these are the various things which we have already discussed. Now, future. Future is how do we treat and how do we prognosticate? So this is a simple flow chart. Just understand this much and that's all that we have done for the day. Platelet count first less than 1.5 lakhs. First thing, whether the patient has got an organ impairment, yes or no. If patient has an organ impairment, is there a significant drop in platelet count? If yes, then please read, I have not written platelet transfusion, I have written anti-thrombotic therapy as a paradox. The reason being, that means patient is having severe DIC, he is having microvascular thrombosis, please go ahead and give anti-thrombotic therapy. Now, how do you give it? Please take the help of a hematologist because I am very clear about it. Anti-thrombotic therapy in the view of thrombocytopenia is not general physician's purview. It should be referred to a hematologist and hematologist should take care of it because we have to make sure that whatever is the platelet count, your anti-thrombotic therapy type and method has to be dependent on that. To make it very simple, we give unfractionated heparin till 25,000. Less than 25,000, you have to think whether to give simultaneous transfusions and anticoagulation or to give half dose heparin or to make sure that the patient is being managed and closely monitored. So that part, leave it to him. Now, if patient does not have organ impairment, understand whether the patient has a bleeding or not. If the patient has a bleeding, is thrombocytopenia the cause for bleeding or not? Or is it raised PT, APTT? If it is raised PT, APTT, then in that case, as Maitri ma'am told you yesterday, component support. If no, then platelet dysfunctions are very common. If the thrombocytopenia is cause for the bleeding, then is the only reason when you should transfuse platelets. So concept, if a patient is bleeding, do PT, APTT, PT, normal, give FFPs. If PT, APTT are normal, D-dimer is not raised, then only give transfusions. So if you look at the complete cohort, this number of patients who require platelet transfusion in your ICU setting will be 1 out of 100. But what do we see in daily ICU settings? 90 out of 100 get platelet transfusions before even being referred to a hematologist. Please don't do that because it worsens inflammation, it worsens complement activation, it worsens leukocyte adhesion, and it will actually worsen your multi-organ dysfunction. So don't give platelets at the drop of your hat. So this is the same thing just to show, and this is what I have already discussed, so I'll not go into the detail of this, of where do we do and other things. So to conclude, thrombocytopenia in ICU is very common. It correlates with adverse prognosis. There are multiple mechanisms which will contribute to thrombocytopenia. Differentiating the causes in every individual patient is very challenging, and you need not actually put in that effort to identify what pathophysiology it is until unless it has a therapeutic relevance. And looking back at patients' medical history and the previous illnesses is very, very important. And optimal transfusion strategies by understanding that flow chart is very important.